throughout the course of the webinar, I have placed different multiple choice interactive questions. Sometime we'll begin with questions and sometime we'll review the questions after the discussion. It is not about getting the questions right. It's about sharing what you feel about the right answer so that I can also know my audience and accordingly tailor the discussion. And when a question comes on the screen, you can simply answer by choosing the right option. So suppose there is a question that has 4 options, A, B, C, and D. If you think C is the right answer, you just write C in the chat box. And that way I can also understand how the answers are distributed in the audience today. Also, if you have any question, you can always type in the chat box. And to write yes, you can simply write Y. And to denote no, you can simply write N. And if you don't understand something, feel free to write into the chat box. Some of the questions which are extremely relevant, I'll try to address them immediately. And some, if I feel are not exactly related to the topic that I'm discussing, I'll take them up at the end of the session and answer them one by one. So let us start. So the first part is to understand the cardiac cycle and the symptoms of the heart disease. Now, whatever be the kind of heart disease that we are talking about, whether it is mitral stenosis or mitral regurgitation or an ischemic heart disease or a congenital heart disease, finally, all heart diseases end in heart failure. So it is very important to understand how heart failure manifests in different manners, and that is the only way we can understand the clinical features of valvular heart disease. Because although valvular heart diseases are of different types, the final outcome of all the diseases is heart failure. So let us quickly review the symptoms of cardiac failure or cardiac diseases. So this is the first review question for you. Try to answer this. I would encourage all of you to try. Left ventricular failure is characterized by which one? A. Pedal edema. B. Cough with pink frothy sputum. C. Soft and tender hepatomegaly. D. Engorged neck veins. And E. All of the above. So most of you have gone for B, while some are opting for E. We'll see which is the correct answer. Let us move on to the next question. We'll again come back to these questions after the discussion is over. Right ventricular failure is associated with A. Hepatomegaly, B. Splenomegaly, C. Ascites, D. Pedal edema, E. All of the above. Okay, so we are getting some unanimous kind of answer through E. Let us move on to the third question. Forward feature of left ventricular failure includes. So you read the 5 options and you see which one is the most perfect forward feature of left ventricular failure. We'll move on to the fourth question. A clinical feature that can be produced by both forward and backward features in left ventricular failure. So which of these features can be produced by both forward mechanism and backward mechanism? Okay, so we are getting most responses in the form of E, and some are opting for B as well. Vidhi, your microphone is on. It will be good if you can switch it off. The final question, after which we go into the discussion. In left ventricular failure, pulse rate is usually normal, high, or low. Okay, so we have most people opting for low, while some are going for high. Fine. With these preliminary questions, let us enter into a discussion where we'll find answers to these questions. And then we'll get back to these questions once again and check our answers. So it's important to understand before we start discussion on any cardiac disease that what is heart failure. Literally, it means that the heart is not functioning properly. But there are some very specific pointers that should be remembered to define heart failure. First, I'm reading this and then I'll highlight a few portions out of this. So, we usually say that heart failure is a clinico-pathological condition where the heart is unable to generate sufficient cardiac output to meet the metabolic demands of the body in presence of normal or elevated venous return. What does this technical definition actually mean? If you see the definition very carefully, the definition has a few salient parts. First, it says that it is a clinico-pathological condition. So, heart failure is as much a clinical feature as much an organ pathology. Second, this part is fairly simple to understand. This is what failure means. It is unable to generate sufficient cardiac output. So, this I think is the easiest part of the definition. But what is very important here is the next part that follows. To meet the metabolic demands of the body. Now, what is so peculiar about this line? Why am I highlighting this line? Because this means if the metabolic demand of the body is increased due to some other pathological process, then even the normal cardiac output will be considered to be insufficient, and the condition can be called heart failure. Suppose that there is a person with thyrotoxicosis, or a person with pheochromocytoma, or a person with an arteriovenous shunt where the metabolic demand of the body has increased. Or suppose there is a lady with pregnancy where one heart is pumping for two human beings. In this condition, if the cardiac output does not increase proportionately, then the non-increased cardiac output, whose value may be simply normal, like 5 liters per minute, in spite of that, you can call it insufficient, and therefore you can call it heart failure, because it is unable to meet the metabolic demands of the body. You can always call it heart failure secondary to something, that is not a problem, but in spite of that, it still remains a heart failure. So a value of 5 liter or 6 liter of cardiac output per minute may not always signify that there is no heart failure. You should also check clinically whether the metabolic demands are met in a physiological or in a pathological situation. And then comes the most important hemodynamic parameter. In presence of normal or elevated venous return. What does this mean? This simply means that we know from our knowledge of cardiac output, Frank Sterling's law predicts that the cardiac output Many people are requesting to annotate. Please don't request to annotate. So we know that cardiac output is proportional to the venous return or end diastolic volume. Within a physiological limit. What this definition is trying to say is that suppose for some reason the venous return decreases. That means no blood is coming back to the heart. If no blood or less blood is coming back to the heart, we cannot blame the heart for pumping less. So then it is not cardiac failure, it's circulatory failure, better called shock. This is the definition based on which we will differentiate hypovolemic shock or distributive shock from a cardiogenic shock or heart failure. In heart failure, typically supply of blood to the heart is normal or even more than normal. But in spite of that, the heart cannot pump. So heart failure is essentially a pump failure. On the other hand, if a person has severe diarrhea, severe vomiting or bleeding for which the blood volume has decreased and therefore the cardiac output is less, this is not a cardiac failure. This is shock because the venous return has decreased and we cannot blame it on the heart. So this is probably the most important part of the definition, that the decrease in cardiac output will happen in presence of a normal or elevated venous return. If the venous return has decreased, you cannot blame the heart for that, and then it will not be considered to be a heart failure. So up to this, is this definition clear to everyone? If yes, you can write Y in the chat box. Have you understood what are the nitty-gritties of this definition of heart failure? Okay. So before we proceed with the signs and symptoms of cardiac failure and different valvular heart diseases, we'll very quickly understand the clinical features of heart failure. So as we have defined heart failure as a situation where the heart cannot generate adequate cardiac output to meet metabolic demands of the body in spite of a normal or elevated venous return. Let us see what happens in a setting of this. So suppose there is cardiac failure. Once there is cardiac failure, it will totally depend on which ventricle we are talking about. So cardiac failure based on the side of the heart affected can be a left ventricular failure or right ventricular failure. When both ventricles cannot perform properly, then that condition is called biventricular failure. And we can also get isolated left ventricular failure. For example, if there is a myocardial infarction involving only the left ventricle. We can also get isolated right ventricular failure if there is a trauma or myocardial infarction only involving the right ventricle. So that is also possible. So how will clinical features of heart failure vary? Heart failure can be classified in different ways. Heart failure that appears very rapidly within weeks are known as acute heart failure. And heart failure that takes years to develop are called chronic heart failure. Acute heart failure usually indicates a recent injury to the heart or acute injury to the heart. And therefore it can be found in very acute conditions like acute rheumatic fever. It can be found in infective endocarditis. It can happen in trauma, including surgical trauma to the heart. Whereas when you talk of chronic heart failure, they are usually result of a slow pathology, an ongoing pathology. And this typically happens in valvular heart diseases and in chronic ischemic heart diseases. Acute ischemic heart disease like myocardial infarction will cause acute heart failure. Whereas a chronic ischemic heart disease like a long-standing stable angina might lead to a chronic heart failure. by gradually damaging the muscle fibers. Heart failure can also be classified based on which side of the heart is affected, as we saw. So it can be classified into left ventricular failure, right ventricular failure, and biventricular failure. Heart failure can be classified based on the cardiac output. Normally, the cardiac output decreases in heart failure, and that common type of heart failure is also called low output heart failure. But as I told you, in some special situations like thyrotoxicosis or pregnancy, cardiac output may be normal or high, but in spite of that, it cannot meet the metabolic demand of the body. Such special conditions are called high output cardiac failure. Heart failure can also be classified based on clinical features. And based on clinical features, the symptoms are sometimes classified as forward failure and backward failure, although both will happen simultaneously. Now I will explain what is forward failure and what is backward failure. So this is one way of classifying heart failure based on duration, anatomical side involved, on the cardiac output, and on the clinical features and manifestations. Now, what happens when the heart suddenly stops pumping or develops a low cardiac output state? To understand this, we need a very simple idea about the operating system of the heart and the cardiac cycle. So you see, suppose this is the right atrium, right ventricle, left ventricle, and left atrium. In between, we have the interatrial and interventricular septa and the valves that separate them. Now, let us make a very simple working diagram of this. Blood normally, after coming into the left atrium, will flow into the left ventricle through the mitral valve. This blood is then pumped out to different parts of the body. Through the aorta and its branches. From the different parts of the body, the blood will return through the superior and inferior vena cava into the right atrium. Blood from right atrium moves to the right ventricle through the tricuspid valve. And from the right ventricle, the blood will go to the lung through the pulmonary artery. From the lung, oxygenated blood will return to the left atrium through the pulmonary veins. So the vessels concerned here are aorta and its branches, that is the systemic arterial system. The blood from the right ventricle to the lung goes through pulmonary artery. The blood from lung back to the left atrium comes through the pulmonary veins. So this is the simplest way to represent the operating system of the heart. But however, this very simple diagram is very useful to understand the features of heart failure. Let us start discussion with the left ventricle. What would happen if the left ventricle stops pumping? If the left ventricle stops pumping, then the blood that was supposed to go through aorta to different parts of the body, that will no longer be able to go. So there will be an interruption at this step. Now, as different parts of the body will not receive adequate blood, so gradually they will start developing clinical features. In the skin, they will develop pallor. The skin will also develop cyanosis because of excess extraction of oxygen from small amount of blood. In the heart itself, as coronary circulation also is a branch of the aorta, so there will be angina. The kidneys will get less blood and there will be oliguria. The brain will get less amount of blood, so there can be syncope and confusion. On the other hand, as left ventricle is not pumping blood, see, the definition was that heart failure occurs in a background of normal or elevated venous return. So blood is continuing to come into the heart, but it cannot be pumped. Under such situation, as blood cannot go out, the problem will be blood will start to accumulate. So a time will come when the whole of the left ventricle is filled with blood. This kind of filling with blood is known as congestion. Once the left ventricle becomes filled with blood, blood will backflow because there is no forward flow. So the left atrium will start now getting congested with blood. So there will be left atrial congestion. When the left atrium is totally full, then the blood will start to flow backwards into the pulmonary veins. And thereafter, the hydrostatic pressure in the lung capillary, which is also called pulmonary capillary wedge pressure, will rise. This will lead to transudation of fluid causing pulmonary edema. So you see these arrows, follow these arrows, and you can easily understand this is due to backward collection of the blood. So these features like atrial congestion, pulmonary venous congestion, elevated pulmonary capillary wedge pressure, and finally pulmonary edema. These are all examples of backward features of left ventricular failure that happen due to backward accumulation of blood. The concept of forward and backward is from the point of failure. Here the left ventricle has failed, so anything that is happening in front of the left ventricle in the circuit is forward feature. Anything that is happening behind the left ventricle in the circuit is a backward feature. So I hope this is clear to everyone. Fine. So we had some idea of what are forward features and what are backward features. Similarly, if we go in a similar manner, we can also understand how the right ventricular failure will manifest. When there is right ventricular failure, I'm using a different color only to show the differences. So when we go to the right ventricular system, superior and inferior vena cava are returning blood to the right atrium and then into the right ventricle for oxygenation. Now here the problem lies with the right ventricle. If right ventricle doesn't pump blood to the lung, oxygenation will suffer. Although this never becomes a big problem because the pressure gradient of pulmonary circulation is relatively low. As the pressure gradient is low, even with a little bit of pressure, the blood can go to the lung. So the forward feature, which is ideally pulmonary hypoperfusion, hypoperfusion means less blood supply. Technically, this does not become very prominent. First, because the pressure required to pump blood into lung is very low. Second, because the lung has a dual blood supply. So because of this, pulmonary hypoperfusion is a rare complication. However, backward features become very prominent. So how do backward features affect the right ventricle? In the right ventricle, as it starts to fail, the right ventricle will become totally filled up with blood, and this is known as congestion. So congestion means accumulation of blood. passive accumulation of blood. After some time, when the right ventricle is totally filled up, blood will move backward and the right atrium will become filled up. After that, there is no more space. So, when blood is trying to return from the superior vena cava and inferior vena cava into the right side of the heart, it finds no place. So, the block appears at a level like this. As the superior vena cava starts accumulating blood, it will produce certain clinical features. Congestion of the superior vena cava leads to engorged and pulsatile neck vein. Neck vein stands for the internal jugular vein. The neck vein drains into superior vena cava, so it accumulates blood and becomes congested. So this is the backward feature. In case of inferior vena cava, you know the blood vessels below the diaphragm drain into IVC system. So none of these blood vessels will be able to drain back. The result will be all organs that drain directly or indirectly into the inferior vena cava will accumulate blood and will become congested. So there will be pedal edema. When in general survey we say edema, we refer to pedal edema. Then blood will gradually move upwards, accumulate in the liver, because the liver also drains into the inferior vena cava system, and so there will be soft and tender hepatomegaly. Soft because it's filled with blood, tender because of the stretching of the capsule. Similarly, the portal vein will now get congested, which drains into the liver. This leads to portal hypertension. And one of the features of portal hypertension will again be splenomegaly and ascites. So this is how typically the backward features of inferior vena cava congestion will manifest. So to summarize, you see, in the pulmonary veins, backward feature includes atrial congestion, pulmonary venous congestion, raised pulmonary capillary wedge pressure, and pulmonary edema. Here I am asking one question to all of you. If the lung becomes filled with water due to pulmonary edema, will gas exchange be affected? Will oxygen delivery be affected? Yes. So this can also lead to cyanosis. So cyanosis in the forward feature is due to reduced blood flow, and that is why it is known as peripheral cyanosis. Cyanosis due to the backward feature is due to improper oxygenation, and therefore it is known as central cyanosis. So in left ventricular failure, we can see both central and peripheral cyanosis occurs. The central cyanosis is a feature of backward failure, whereas the peripheral cyanosis is a feature of the forward failure. Right ventricular failure does not cause cyanosis. Right ventricular failure causes systemic edema in the form of pedal edema, hepatomegaly, ascites, splenomegaly, portal hypertension, and engorged and pulsatile neck vein. Forward features of left ventricular failure are all due to reduced blood supply to different organs, causing pallor and cyanosis of the skin, angina in the heart, oliguria in the kidneys, and syncope or dizziness in the brain. So is this model of heart failure clear to everyone? Because ultimately all valvular heart diseases will land up in these features. Yes, I will repeat the central and peripheral part. Cyanosis means bluish discoloration of the skin and mucosa due to higher level of deoxyhemoglobin. Now, cyanosis therefore requires the blood to be deoxygenated. The deoxygenation can happen by two mechanisms. One mechanism is that the tissues are taking up more oxygen because they are getting less oxygen. The tissues are taking up more oxygen, making the blood deoxygenated. The second mechanism may be that the lung is unable to oxygenate the blood properly. When the problem lies with less blood supply to the tissue so that more oxygen is taken out, that is called peripheral cyanosis. That typically happens if there is reduced cardiac output or reduced blood flow to the organ. And when the cyanosis is because the oxygenation process of the blood is hampered due to a lung problem or due to a cyanotic heart disease, then it is called central cyanosis. So in central cyanosis, cardiac output is not less. Instead, the process of oxygenation of the blood is affected. So the problem most often lies in the lungs. Now you see in left ventricular failure, there is pulmonary edema, that's a lung problem that is impairing oxygenation. So this should be called central cyanosis. Also in the same disease, there is reduced cardiac output. So tissue is extracting extra oxygen, making the blood rapidly deoxygenated. This is peripheral cyanosis. So both central and peripheral cyanosis can happen in left ventricular failure. So I hope this is clear. Okay. So we now move on to the questions that we started with. We started with a few questions as introduction, and let us see if you can answer them properly now. So left ventricular failure is characterized by, what will be the right answer? Very good. Left ventricular failure is characterized by cough with pink frothy sputum. This pink frothy sputum is the pulmonary edema fluid. The fluid of pulmonary edema is pink and frothy. It's frothy because of the cough, and it's pink because due to pressure, some capillaries with high pulmonary capillary wedge pressure can rupture and blood is added to the water, making it pink. But you see, in left ventricular failure, there is no pedal edema. That's a feature of inferior vena cava congestion. There is no soft and tender hepatomegaly, which is a sign of inferior vena cava congestion. Engorged neck vein is a feature of superior vena cava congestion. They are all right part of the circuit. So pedal edema, hepatomegaly, and engorged neck vein are features of right ventricular failure. Only cough with pink frothy sputum is a lung symptom, most likely to be a feature of left ventricular failure. No, left ventricular failure features are not usually associated with right ventricular feature. They will only be associated if there is a biventricular failure. As the question specifically says left ventricular failure, we will not consider this to be a biventricular failure. Okay, fine. So right ventricular failure is associated with, now this is a very easy question. Wonderful. So all of these, option E is the right answer. It will be manifested with hepatomegaly, splenomegaly, ascites, and pedal edema. Forward feature of left ventricular failure includes which one? Very good. The answer is pallor. All of the other features, as you can see, are backward features or congestive features. A clinical feature that can be produced by both forward and backward mechanism in left ventricular failure. Wonderful. The answer is cyanosis. Previously, many of you had answered edema. So understand, whether you are talking of pulmonary edema or systemic edema, edema is always a backward feature. Forward feature cannot cause edema. So the answer is cyanosis. The forward mechanism is peripheral cyanosis and the backward mechanism is central cyanosis. In left ventricular failure, pulse rate is. Kunjal, I already said forward feature means that blood is unable to enter a particular organ. So all features due to reduced blood supply is forward feature. Now, here many of you had answered low, some are considering it to be high. Understand one thing. If there is left ventricular failure, cardiac output will be low. If cardiac output is low, then the blood pressure will be low. If the blood pressure is low, then by baroreceptor mechanism, there will be reflex tachycardia. That is why in left ventricular failure, pulse rate is usually high due to activation of the baroreceptors. As BP falls, the pulse rate rises. This also follows Murray's law, which says that pulse rate will rise when BP falls. So there is a tachycardia, it's a compensatory tachycardia due to the baroreceptor activation. So as we understand the basic features of heart diseases, let us now go into cardiovascular system examination. Before we start discussion, let us test our knowledge. So I want all of you to answer. Visible impulse over epigastric area may be due to. We are talking in terms of cardiovascular disorders. So visible impulse over the epigastric area may be due to. So we're getting a mixed response between C and D. Let's move on to the next question. Visible impulse over the left second intercostal space may be due to. Left second intercostal space. Fine. We are totally split up into the responses here. Let's go to the next question. Tapping apex is seen in. Okay, we'll move on to the next question. Loud first heart sound is a feature of. Okay, next question. Splitting of second heart sound is best heard. A during early inspiration, B during early expiration, C while holding the breath after expiration, D while holding the breath after inspiration. Okay, fine. Next question. Presence of thrill indicates that the murmur is at least grade 1, 2, 3, or 4. Okay, so we'll move on to the next question. A murmur of pulmonary stenosis is best heard at the height of inspiration, expiration, both, or none. That means it's not related to respiration. Okay, the next question is, a high-pitched murmur is best heard with the bell or the diaphragm. Next question. A systolic murmur is heard right after which heart sound? The final question before we start our discussions. In acute injury or inflammation of a heart valve, the first murmur to appear is of. That is, right after you injure the valve, what will you get? A murmur of stenosis, murmur of regurgitation, both, or none? Okay, so with this basic discussion, let us start our analysis of these topics, and we'll come back to these questions to see what the right answer would be. When you do an examination of the cardiovascular system, you pretty much follow the same format that we follow in other systems. Starts with a history, then you do a general survey, then you do precordial examination, which is essentially the cardiovascular system examination, and a systemic survey through all the other systems like respiratory system, GI system, renal system, etc. So in the history, essentially, you ask about the symptoms of the disease, whether the patient is having breathlessness, chest pain, the duration of it, the family history, past history, history of any previous treatment or hospitalization. Now, let us start with what is the importance of general survey in a patient with cardiovascular system disorder. See, when a patient presents to you, the first test that you are doing is general survey. And most often I have seen students ignore this portion so much that they miss out on a lot of important information. General survey is called general because it gives information on all systems of the body. It helps you determine whether you are actually dealing with a cardiovascular system disorder or the differentials include other systems. So look for the alertness, consciousness, and cooperativeness of the patient. It is not only important that the patient is alert to give you history, it's also important if the patient is not conscious. Maybe you are dealing with a case of extremely low cardiac output that can happen in, say, very tight aortic stenosis where blood cannot reach the brain, in carotid artery disorders like carotid stenosis. It can be a manifestation of cerebral embolism or infarct, that is cerebrovascular accident, which are often complications of cardiovascular diseases. So it is very important that you check the alertness, consciousness, and cooperativeness of the patient. Phases is very important because sometimes you will get patients with cardiac diseases who have cyanosis. So there may be a cyanotic hue over the face. Even before you do a formal examination of cyanosis, this is the first clue that you are dealing with hypoxic patient. Also important is there may be wasted faces. Wasted faces means the face looks as if the person is extremely malnourished, with sunken cheek, with sunken eyes, etc. Malnutrition is often a feature of cardiac disease because as cardiac disease happens, patient becomes breathless, and a breathless patient cannot eat properly because while eating you have to stop your breath. That is why cardiac and respiratory diseases often cause reduced food intake. Also, because of the backward feature of right ventricular failure, the intestines may be totally congested. So the lacteals and the capillaries may not be able to absorb the food properly, also causing malnutrition. So it's very important that you look at the faces and get some idea of the backgrounds of the patient. Then we come to decubitus. Decubitus essentially refers to how the patient prefers to sit. In a patient who is not having active symptoms right now, the decubitus may be off choice. That is, the patient can sit in any way the patient likes. But if there is active breathlessness, you will see often patients are sitting propped up. Because when we sit up, the diaphragm moves down, giving more tidal volume. Also, the venous return decreases, decreasing the chance of congestion. Look into the build and nutrition. Build is the skeletal framework. That is the height, the arm span, etc. Whereas nutrition refers to the soft tissue mass. Build can be measured by anthropometry, whereas nutrition can be assessed by body mass index, by using other indices like the say for example various circumferences like the waist versus hip ratio, by the abdominal circumference for central obesity, etc. It's very important to look into this from cardiac point of view. Obesity is associated with ischemic heart disease. That is why indicators of obesity should be routinely sought in patients who have history of chest pain. For example, a BMI more than 30 includes obesity. Waist hip ratio of more than 0.8 might indicate a central obesity. Similarly, the skeletal framework sometimes gives you clue to very specific diseases. For example, if a person is very tall, has arachnodactyly, or has a subluxated lens, then it can give clue to diseases like Marfan syndrome. These are syndromes of abnormal collagen synthesis, and so valves can also become abnormal. Diseases like aortic regurgitation or mitral regurgitation may be more common in patients with Marfan syndrome. Look for pallor. Pallor can indicate anemia, which is a cause of hyperdynamic circulation, or pallor can be a result of poor blood supply, which can indicate a forward feature of left ventricular failure. Move on to cyanosis. We already know how cyanosis is important in cardiovascular diseases. So in case of left ventricular failure, there may be both central and peripheral cyanosis. Icterus refers to jaundice. Now, jaundice per se is not a feature of cardiovascular disease. So if there is jaundice present alongside, you should think of some rarer combinations or different other kinds of diseases that may be present. So I can just give you an example. You may be having a patient who has, for example, pallor, jaundice, and heart failure. If such a combination comes to you, think of an active hemolytic process. So is it that there is a hemolytic anemia that is causing both pallor and jaundice? And is it the lack of this hemoglobin causing hyperdynamic circulation and a resultant cardiac failure? Or are we dealing with a long-standing heart failure which has complicated into cardiac cirrhosis? And then cardiac cirrhosis is leading to jaundice. Or is it that we have two separate diseases? Patient has heart failure, patient might also have a gallstone disease. So these are things that you should keep in mind while assessing symptoms that are apparently not related with the system. Clubbing usually indicates a long-standing heart and lung disease. In the background of heart disease, it is very commonly seen in cyanotic heart diseases and also in chronic heart failure. In cyanotic heart disease and chronic heart failure, oxygen supply to different parts of the body is less. It's even more reduced at the tip of the extremity, which are farthest away from the heart. This hypoxia stimulates fibroblast at the tip of the finger, and this causes deposition of tissue matrix, and this causes swelling of the finger, causing clubbing. So I'm repeating this. In chronic hypoxic state, the tip of the finger, being the most distal part of the body, are affected from severe hypoxia. Hypoxia stimulates the fibroblast. They deposit glycosaminoglycans, collagen, and other tissue matrix proteins, and they cause swelling up of the nail bed, leading to clubbing. So if you get clubbing in a patient with valvular heart disease, it might indicate you are dealing with a long-standing disease as compared to an acute onset disease. In general survey, when we talk about edema, we specifically talk about bipedal edema. And this typically indicates a right ventricular failure process. Pulmonary edema is examined under respiratory system examination. So we don't examine that under general survey. Yes, skin fold thickness you can also measure to assess nutrition, not build, because skin is a soft tissue. So you can take the skin fold thickness over the triceps muscle, and that can be an indicator of the nutritional status and not build. Then comes the neck vein. We have already seen that the neck veins can be engorged and pulsatile in right ventricular failure. Be careful to see that the neck vein is pulsatile, because an obstruction at the base of the jugular vein can also cause engorgement of the vein. But if there is an obstruction, then the vein will not pulsate. So in diseases where there is jugular vein thrombosis, or if there is a metastasis to the base of the jugular vein, then also you get engorged neck vein, but they are engorged non-pulsatile neck vein. Whereas if you get engorged pulsatile neck vein, it indicates congestion without obstruction. That is typically found in right ventricular failure. We come to the discussion on neck glands. Neck glands are not directly related with cardiac diseases, but you have to routinely examine them. Maybe by neck gland examination, you find that there are submandibular lymphadenopathy. And then looking into the oral cavity, you find out there is caries tooth. You get a history of tooth extraction recently. This can indicate how the person developed an acute bacterial or subacute bacterial endocarditis. Neck glands can also indicate if the overall oral hygiene is good or bad, predisposing them towards infective endocarditis. So examination of the neck gland is usually a useful process. When we look at the pulse, it's important that you look at all the points that we examine in pulse. That is, you look for the rate, the rhythm, the volume, the character, the presence of any delay, and the character of arterial wall. All these points have to be taken into consideration. They give ample evidence of the underlying pathology. As we just now saw, that in some diseases like heart failure, rate can be high. On the other hand, if you get a very low heart rate, maybe you are dealing with some kind of an AV nodal block. If the rhythm is regular, then there is nothing to bother about. But if the rhythm is irregularly irregular, then probably you are dealing with atrial distension, which has led to atrial fibrillation. We have just now seen that atrial distension is a very common process as backward feature of left ventricular failure. We will later on see it's very common in mitral valve diseases. Volume refers to the thrust that we feel in the hand. It's an indicator of pulse pressure. So if the patient is having heart failure, there will be low volume pulse. If the patient is having high output cardiac failure, as in thyrotoxicosis, there can be high volume pulse. Character refers to the waveform of the pulse. And I'll discuss about this right now after I discuss the rest. Delay means when the pulses in two extremities do not appear simultaneously. A delay between two radial artery pulse is radioradial delay, and that between radial and femoral artery pulse is radiofemoral delay. Delay essentially means there is an obstruction. So that can be due to a thrombus, due to a metastasis, due to a lymph node, many other processes that can compress on one of the arteries. Character of the arterial wall typically tells you whether there is an atherosclerotic process going on, indicating ischemic heart disease. Again, look at the blood pressure. The systolic blood pressure corresponds more accurately with cardiac output, and the diastolic more accurately with peripheral resistance. So when you are commenting on heart failure, it's important to see that the SBP might have fallen down, but it's always appropriate that you take history of hypertension. Maybe the baseline pressure of the patient was 160 by 100. Due to heart failure, that has come down to 120 by 80. But you are considering 120 to be normal here. It's not normal. It's reduced from the previous value. That is what heart failure has done to this person. It's important to check respiration. If there is pulmonary edema, then there will be severe dyspnea and the patient may actually have a labored breathing. Temperature is a very important indicator because fever increases metabolic demand of the body. And as metabolic demand increases, a compensated heart failure can become decompensated. So these are the importances of general survey examination in a patient with cardiovascular disease. I'll talk about the character of pulse. So other than the character of pulse, are everything more or less okay? Did you understand the relevance of doing an important meticulous general survey? in examination of valvular heart disease? Fine. Now, when we talk about character of a pulse, it means how the pulse will look like if we trace it graphically. Graphical tracing of pulse can be done by various techniques. A manual method of tracing the pulse is doing a sphygmography. That can be done by using a sphygmograph or a student's physiograph. And of course, there are digital techniques. So there is also digital arterial pulse tracing. Now, when you look at a pulse, the wave of the pulse is essentially a graph. The x-axis of the graph indicates changes in pressure. The y-axis of the graph indicates changes in time. As unit of the cardiac cycle, instead of measuring in second, we can actually divide the time in systole and diastole. Systole is shorter and diastole is longer. Under usual circumstances, when an arterial pulse is traced, a normal arterial pulse will look somewhat like this. I'm trying to draw here. I'm not very sure how well I'll be able to draw. So this is the appearance of a normal arterial pulse, where I repeat again, we are plotting pressure against the y-axis and time against the x-axis, where the first part is systole and the next part is diastole. And diastole is longer than systole. When the left ventricle starts to contract, the pressure in the left ventricle sharply rises. And this sharp rise in the left ventricular pressure is reflected in this first curve. As the left ventricle pressure rises and the pressure starts to rise in the artery, after opening of the aortic valve, the arterial pressure also rises. So the left ventricle contracts, aorta opens up, blood starts flowing into the aorta. Now, aorta, being an elastic vessel, will stretch, and this stretch causes manifestation of increased pressure. So this upward curve is due to the left ventricular systole, an entry of blood in the aorta. This upward curve is also known as, therefore, the tidal wave or the percussion wave. So what is the meaning of tidal wave? Tidal wave represents left ventricular systole and entry of blood in aorta and this causes a severe rise in pressure. Understand one thing, that the blood does not cause rise in pressure. It is the contraction that causes the rise in pressure. It is very much like 1,000 people are standing in a line. If the last person at the back pushes, immediately the first person in the front will fall. It is not the mass that is propagating, it is the pressure that is propagating. It's very much like the flow of sound wave. Thereafter, as blood has gone out, the aorta recoils and the aortic valve closes. This is the point of closure of the aortic valve. At the point of closure of the aortic valve, there is a fall in pressure, leading to the formation of a notch. And then the remaining blood reflects on the closed aortic valve and again moves forward, leading to the second wave. The second wave is called a dicrotic wave. And the notch is called a dicrotic notch. So tidal wave is because of left ventricular systole and entry of blood or the pressure of the blood in aorta. Whereas the dicrotic wave is due to reflection of blood from closed aortic valve. Therefore, dicrotic notch will represent the point of closure of aortic valve. Understanding the normal pulse wave is very important in today's class, because tomorrow when I start talking about the abnormal pulses that we get under different valvular heart disease, you have to correlate and understand why the graphical structure or the waveform is changing. Once you understand the normal mechanism, you can easily calculate how the abnormal pulse will look like. So are the parts of a normal arterial pulse tracing clear to everyone? This will require revision. So of course you will get one day to revise through this. Wonderful. So now we move on to the next part of the cardiovascular system examination, also known as precordial examination. The part of the chest, the anterior chest wall, that directly lies over the heart is known as precordium. So in cardiovascular system examination, we don't have to examine the whole chest. We examine mainly the precordium. So by now you must be knowing that the precordium has four important areas: the mitral, tricuspid, pulmonary and aortic area. And then there are some special areas like Erb's point, etc. Now, when we talk about these areas, one common misconception is that these areas are landmark of the various valves. It is not. First, make this concept very clear. Mitral area does not represent the point where mitral valve is located. Aortic area does not represent the point where aortic valve is located. So what are these areas for? When a particular valve closes or opens, or when blood flows through a particular valve, a turbulence is created that causes certain kinds of sound. They may be normal sounds like the heart sounds. They may be abnormal sounds like murmurs. So whether they are normal or abnormal, there are sounds produced in different valves. These areas on the precordium represent the point where the sound is best audible. So these are points of best audibility, the point where you can hear the sound more accurately or clearly. They do not represent the position of the valve. Say for example, in a room there is a speaker on the wall and there is a corner in the room where the reception of the sound is best. That corner is the area on the precordium. We are not pointing out where the speaker is. This is exactly like that. So the valves are located much deeper. What is the mitral area is the area where sound of the mitral valve travels best. Aortic area is the point where the sound of the aortic valve travels best. So I hope this is clear to all of you. So technically there are four areas, as you can see. If I go to the next diagram, it will be easier to visualize. Then I'll come back to this diagram. One way by which you first start locating the areas is, first you find out the area of the apex beat. So you locate the apex with your palm, ulnar border and finger. I'll come to the discussion on apex very soon. So once the apex beat is located, the area of the apex beat is called mitral area. So mitral area is synonymous with the position of the apex beat. In a normal person, it is in the fifth intercostal space on the left side, half-inch medial to the mid-clavicular line. Now you can ask me that, sir, if someone has a pathology and the apex is not in the normal position, then which area should be taken as mitral area? The new changed position of the apex is the mitral area for that person. So wherever is the apex of the individual, that area is called the mitral area. So mitral area is not localized just by counting ribs. Mitral area is ideally localized by finding the apex. You mark the apex and call that area the mitral area. I hope this is clear. So next comes the pulmonary and aortic area. One important landmark in clinical medicine is the junction between manubrium sterni and the body of the sternum. This is called the sternal angle or the angle of Lewis. If you touch your own sternum, you will see there is a slight undulation there where the two bones meet. This corresponds with the second rib. So the space below this is the second intercostal space. So if this is the midline, then just beside the sternum are the two areas, pulmonary area and aortic area. Pulmonary area lies on the left side. Aortic area lies on the right side. For beginners, this can be a shock because we believe that pulmonary artery is originating from the right ventricle and aorta is originating from left ventricle. So why are these areas in opposite position? If you see the normal structure of these blood vessels, you can easily understand from the left ventricle, the aorta curves like this. So I'll draw this once again for you. Sorry. So from the left side, aorta curves like this. Similarly, from the right side, when pulmonary artery is originating, it bifurcates like this. Because the left-sided artery comes to the right side and the right-sided artery comes to the left side. So although the valves are in opposite position, the sound is heard along the flow of the blood. That is why the aortic valve, which is actually a left-sided valve, its sound is better heard on the right side. The pulmonary valve, which is a right-sided valve, its sound is heard better on the left side. This is because of the anatomical crossing of the great arteries. So for this reason, remember that the pulmonary artery or pulmonary valve is on the right side of the heart. So pulmonary area is on the left side of the precordium. Aortic valve is on the left side of the heart, but the aortic area is on the right side because the arteries cross each other. And I mention again, they do not represent the location of the valve. They represent the area where the sound is maximum. Is this clear? Why aortic and pulmonary areas are on apparently opposite positions? Fine. The tricuspid area is very easy to locate. It is not defined as a specific intercostal space usually. We call this the lower left region around the sternum. So this is also called lower left parasternal region. The lower left parasternal region is vaguely called the tricuspid area. So these are the areas. In tomorrow's class, I'll discuss about the Erb's point, which is between the pulmonary area and the tricuspid area. Today, I'm not going to discuss about it. So these are the four areas which are routinely inspected, palpated, and auscultated. Percussion is not done in cardiovascular system for the fear of embolism. If there is a clot in the heart, it can dislodge and cause embolism. That is why percussion is not encouraged. Although there are some special situations where percussion may be done even in cardiovascular system. So I'm repeating the position of the different areas on the precordium. Mitral area corresponds to the position of the apex beat. So wherever is the apex beat is your mitral area. Suppose a person's apex beat is in the normal position, then the mitral area is in the normal position. Suppose a person's apex beat is shifted outwards, then that new point which is shifted outward is also called the mitral area for that person. Suppose a person's apex has shifted inwards, then that new point which is inwards is the mitral area of the person. So whatever is the position of the apex beat of the person is the mitral area of the person. I hope this is clear. The lower left part of the sternum on the left side, the lower left parasternal area is the tricuspid area. You find out the angle of Lewis and find out the second intercostal space. On the left side of the sternum is the pulmonary area. On the right side of the sternum is the aortic area. The positions are apparently opposite because the great vessels cross each other. So these are the four basic areas where different palpation and auscultation can be done. So are these four basic areas clear? Normal person will have the mitral area in the normal position of the apex, that is left fifth intercostal space, half inch medial to the mid-clavicular line. Okay. So this same thing has been reflected in this skeleton diagram. Let the picture load. So you can see this is the same picture basically showing the skeletal landmarks. In the second intercostal space, on the left side you have pulmonary area, on the right side the aortic area. You have the mitral area at the position of the apex, the cardiac apex, and the tricuspid area in the lower left parasternal region. So what are the points that we see while inspecting the precordium? So points for inspection of the precordium. In inspection, you look for any deformity. So if there is any deformity of the precordium, that means the bones are bulging outward or twisted, what does it mean? It usually means, therefore, that the heart enlarged at a time when the bones were not ossified. So the heart was enlarging in a time when the bones were not ossified. So deformity or bulging of the precordium usually indicates a congenital heart disease. If there is a deformity of the precordium, it may be due to a congenital heart disease. Or it can also be due to some trauma or accident over the chest. Always look for a scar on the chest. The scar can be simply a trivial scar. The person can say it is nothing, it's just a scratch from the nail. Or it can also be a surgical scar or traumatic scar indicating damage to the heart or repairing of the heart. So maybe you are getting a particular kind of murmur due to a prosthetic valve, and the clue that the valve is prosthetic lies in the long incision mark that you have on the chest. You have to just ask the patient, what kind of operation did you have? Look for venous prominence. Venous prominence usually means obstruction to venous blood flow. And we already know these are features of backward failure. Now, chest veins will drain into the superior vena cava system. So obstruction to the venous flow here will refer to a right ventricular failure, because left ventricular failure will cause pulmonary feature, not skin manifestation. Skin manifestation will be due to the right ventricular failure. It's very important to look for visible impulses. So you stand at the foot end of the patient and with light falling on the chest, you try to see if any natural pulsation can be seen. Now, natural pulsation at the epigastric area may be due to right ventricular hypertrophy. Natural pulsation in the suprasternal area, that is above the sternum, may be due to an aortic aneurysm of the arch of the aorta. Lower left parasternal region pulsation may again be due to right ventricular hypertrophy. I'll explain why these are happening. Pulsation in the mitral area can indicate a left ventricular hypertrophy, that is a prominent apex. Aortic area pulsation again can be due to aortic aneurysm. Pulmonary area pulsation may be due to pulmonary hypertension. Interscapular, that is between the two scapulae at the back, pulsation may be again seen in aneurysm of descending aorta. Let us try to understand this with some schematic diagram. So see, this is the outline of the heart. In this outline, in the left border of the heart, the upper part of the left border, that is somewhat this position, is represented by the left atrium, or slightly below even. So this position is represented by the left atrium. The upper portion of this is represented by the aorta and the pulmonary artery. The entire long border of the left part of the heart is due to the left ventricle. A large portion of the right border of the heart is due to right atrium. Right ventricle lies inferiorly, it forms the inferior wall of the heart, and therefore this portion represents the right ventricle. Now, as a result of this, right ventricle and left ventricle therefore are not on the same 3D plane. So, when left ventricle undergoes enlargement, left ventricular enlargement occurs in this direction. So left ventricle tries to grow in this direction. Likewise, the right ventricle, on the other hand, grows in a different direction. Right ventricle tends to grow in this direction, and when extremely grown, in this direction. These are the directions, but usually in the horizontal plane. So what happens is, when right ventricle is starting to grow, it grows like this. And because of the bulk of the muscle, the lower part grows. It is not actually growing in the lower direction. The muscle fibers are adding, making it a bit sunken in the bottom part. So as the right ventricle is pushed to the left part, you can easily understand its pulsation can be seen on the left part of the sternum, and left part of the sternum is the lower left parasternal area. That is why right ventricular hypertrophy can cause lower left parasternal impulse. And if the fibers grow at the bottom, it will go below the sternum on the epigastrium area, and therefore epigastric pulsation can also be a feature of right ventricular hypertrophy. Left ventricle, as you can see, grows towards the apex. So the bigger the left ventricle, stronger is the apex. Mitral area is basically the apex. That is why mitral area pulsation, that is prominent apex, is a sign of left ventricular hypertrophy. We have already seen the aortic area is the portion where the aorta is crossing over. So if there is any aneurysm of the aorta, that should be evidently seen here. This is the aortic area. So aneurysm of the aorta in this particular position will cause aortic area pulsation, and if the aneurysm occurs above near the arch of the aorta, then it will be in the suprasternal region. If the aneurysm occurs in the descending aorta, then it will be in the interscapular region. On the other hand, if the pulmonary artery becomes engorged, if the pulmonary artery becomes engorged, then you will get the pulmonary area as the area where there will be a pulsation. So these are the important pulsations or visible pulsations you have to remember. Also remember one very important thing, that whatever is visible is usually palpable. Because if it is so prominent that you can see it, you can definitely touch it. But whatever is palpable may not be visible. So even if you don't get impulse, you always palpate the same areas to see if there is any palpable impulse there. So is it clear how different areas can have visible or palpable impulses under different pathological conditions? Fine. So we now come to the discussion of palpation of the precordium. So what are the points that we see while palpating the precordium? Palpation starts with examination of the apex beat. So you have to examine the apex beat, and once the examination of the apex beat has been done, that means you have not only found out the apex beat but also the mitral area. The apex, you know, is defined as the outermost and lowermost or downmost point on the precordium where a definite cardiac impulse can be felt. So it's the outermost and lowermost point of a definite cardiac impulse. What does it represent? It represents the systolic twisting of left ventricle, of course during systole. That is why it's systoling. So during systole, left ventricle undergoes a spiral motion. Due to this spiral movement of the muscle, it strikes the anterior wall. And this striking is felt as the apex beat. The apex, therefore, will be forceful in all cases of left ventricular hypertrophy. It will be well sustained when it takes longer time to empty the ventricle. Now, ventricle empties through the aortic valve. If the aortic orifice is narrow, it takes a longer time. That is why in aortic stenosis, it takes a longer time to empty and it becomes a well-sustained apex. It will become ill-sustained if the blood rapidly flows out. This will happen if the aortic valve doesn't work, and this is seen in aortic regurgitation. Sometimes the sound of the valve can be so loud that the sound of the valve, that is heart sound, can knock on your hand. You can falsely think that it is apex beat, but actually it is not the apex beat. We will explain later that in mitral stenosis, we get a loud first heart sound. The sound is so loud that it knocks on the hand, on the palpating hand. It seems like an apex, and therefore this is known as tapping apex. So truly speaking, it is not the apex beat, it's the loud first heart sound that seems to knock on your finger. It's important to locate the apex, as we have already learned. If there is left ventricular hypertrophy, the heart moves outward and downward. So apex also moves downwards and outwards. If there is right ventricular hypertrophy, the heart only moves horizontally, not downward. So the apex moves outwards. This is how, from the position and character of the apex, we can have some clue about the kind of valvular heart disease or compensatory hypertrophy that we are having. I'll talk about thrill later. We now come to the discussion of palpable heart sound. I just now told you palpable first heart sound is also known as a tapping apex. P2 or pulmonary component of the second heart sound, if it is very loud, can be palpable. And this is typically palpable in pulmonary hypertension. As in visible impulse, the same logic holds in palpable impulse. So heaving or up-down motion of the lower left parasternal region indicate right ventricular hypertrophy. An impulse in the aortic area indicates aortic aneurysm. So the same causes that cause visible impulse will also cause palpable impulse. So I hope this is clear to everyone. I'll discuss thrill later. Okay. Then we come to auscultation, which is the last part of clinical examination of the cardiovascular system. So auscultation means examining the precordium with the help of a stethoscope. So what are the points that we should follow while auscultation? The basic points are heart rate, rhythm, heart sound, opening snap, ejection click and murmur, and pericardial rub. These are the 7 points that we see. Now see, heart rate is something that should usually correspond with the pulse rate, unless there is a pathology. So it is usually equal to the pulse rate that we have already examined. If they do not match, if you think they do not match, then think of a pulse deficit. Similarly, the rhythm of the heart should be exactly same as rhythm of the pulse. Otherwise, you think of some pulse deficit. Coming to the different heart sounds. You know, the first heart sound is produced by closure of mitral and tricuspid valve. So any pathology of the mitral and tricuspid valve will also change the character of the first heart sound. The first heart sound is therefore typically heard over the mitral and tricuspid area. The second heart sound is caused by closure of aortic and pulmonary valve. Therefore, any abnormality of the aortic and pulmonary valve will also lead to abnormalities of the second heart sound. They are best heard over aortic and pulmonary areas. Third and fourth heart sound are not normally heard. Third heart sound is due to the first rapid filling phase of ventricular diastole, and the fourth heart sound is due to the second or last rapid filling phase of ventricular diastole. Because the pressure of the left ventricle is more than the right, aortic valve closes before the pulmonary valve. So normally the second heart sound has two components, aortic component called A2 and pulmonary component called P2. A2 does not mean there is a A1. A2 means aortic component of second heart sound and P2 means pulmonary component of the second heart sound. Normally A2 occurs earlier and P2 occurs later. The gap between A2 and P2 is called split. Normally the split cannot be properly heard, it's too narrow, but in some diseases it becomes prominent. You can make the split more prominent by asking the person to do deep inspiration and hold. So by holding the breath in deep inspiration, the split can be made prominent. The reason is when you do a deep inspiration, venous return to the right part of the heart increases because chest will suck in blood through the vena cava. Whereas blood flow into the aortic channel decreases because lung is holding back the blood because of negative pressure. So right side of the heart gets more blood, left side of the heart gets less blood. So A2 occurs even earlier because there is less blood. P2 occurs even later because there is more blood and the gap increases. So holding the breath in deep inspiration causes increase in the split. We will talk about opening snap and ejection click in our next class because they are all pathological findings. And then we come to murmur. So what is a murmur? Murmur is actually an abnormal heart sound. So how is it produced? We define murmur as an abnormal heart sound produced by flow of normal amount of blood through an abnormal orifice or abnormal amount of blood through a normal orifice. This is a very interesting definition, you see. So if there is damage to the orifice or the valve, then even normal flow of blood will produce sound. And if the orifice is normal but the amount of blood has increased, then also there will be turbulence and gurgling noise. When the valve is damaged, then that kind of a murmur is known as organic murmur. When the valve is not damaged but only the amount of blood flow has changed, that is known as a functional murmur or flow murmur. Whenever we discuss a murmur is discussed under 5 points. What is the site on the precordium where you get a murmur? For example, if I talk about, say, the murmur of mitral regurgitation, the site may be mitral area. What is the timing of the murmur? Is it systolic or diastolic? The murmur of the mitral regurgitation is systolic. You hear it during systole. By position, we mean what is the position of the patient in which the sound is heard best. The murmur becomes prominent when the person stoops forward, that is, sits in a leaning manner. Whether you hear it with a bell or diaphragm. Now, there is a general rule. Low pitch murmur are heard best with bell. High pitched murmur are heard best with diaphragm. So if the frequency is low, you use bell. If the frequency is high, then you use the diaphragm. So we already know that the pitch of the mitral regurgitation murmur is high. That is why it is best heard with the diaphragm. Then comes the question of quality. How do we describe the murmur? You can use adjectives. So the murmur of mitral regurgitation is typically called a blowing murmur. It sounds like a flute. That is, someone is blowing our flute. So it is called a blowing murmur. Now comes the question of intensity. I told you I will discuss about thrill later. Now, murmurs are graded according to the loudness. Intensity simply means loudness. The classification is very vague. And how do we classify intensity is like this. If you can properly hear a murmur and you can also palpate the murmur, the palpable component of the murmur is known as thrill. So it's like a radio is playing, but you can touch the radio and also say whether it is playing or not from the vibration. This sensation of touch is called thrill. If the volume is very low, then you may not be able to say by touching. So in the same logic, if the murmur can be heard as well as felt by hand, it is said to be grade 4. When it can be heard but it cannot be felt with your hand, then it is said to be grade 3. That means grade 4 has thrill, grade 4 does not have thrill. The rest of the description are funny actually. They say that if the murmur can be heard only by careful inspection, examination, it is grade 1. When the murmur can be heard with a lot of careful invigilation, that is, the first one was almost not heard, it is best located by phonocardiography. The second one is very faintly heard, that is grade 2. Because these are vague, so I always tell my students, never mention grade 1 and grade 2 in the examination. So the simplest thing is, if you hear a murmur, it must be grade 3. Now you look for thrill. If thrill is present, it is grade 4. If thrill is absent, it is grade 3. It's as simple as that. Do not go for grade 1 and grade 2. They can only be found out by investigations. Then people say that if you can hear the murmur with your stethoscope not even touching the chest, it is grade 5. And if you can hear the murmur with your naked ear, you stand beside the patient and you hear the murmur, then it is grade 6. I told you these are very funny. So in clinical practice, we mainly grade murmur as 3 or 4. 3 means murmur without thrill and 4 means murmur with thrill. So in intensity, you write about the intensity. If you get a thrill, then you call it grade 4. Now coming to inspiration and expiration. The general rule is same as the splitting of the heart sound. General rule is left-sided murmur. Murmurs of the left side of the heart become prominent with expiration. Murmurs of the right side of the heart become prominent with inspiration. Now, mitral valve is a left-sided valve. Therefore, it must be better heard during expiration. Conduction means whether the murmur is selectively transmitted in some direction. Not all murmurs are transmitted. The murmur of mitral regurgitation is transmitted towards the axilla. So if you auscultate the axilla, you can hear the same murmur. So these are the 9 points under which a murmur should be described. This is just an example. I will discuss in detail about the individual types of murmurs when I discuss the valvular heart diseases. Finally, if the pericardium is inflamed, the pericardium rubs over itself, and that condition is known as pericardial rub. So you typically get it in pericarditis. So this is the auscultation of the cardiovascular system. This is just an overview. You will understand this much better when I give you actual examples from valvular heart diseases later. So is this clear to everyone? Conduction means when the sound selectively travels in a particular direction. Ideally, sound will travel in all directions, but sometimes due to the anatomy of the body, the sound can travel easier in one direction where the murmur can be heard better. That is called conduction. Okay. So once you have done a good clinical examination, you have had a provisional diagnosis, you have understood what kind of disease you are probably dealing with, it's time for investigations. Chest X-ray is a very important tool. So with chest X-ray, we not only examine the lungs, but also the heart. When heart enlarges in the X-ray shadow, it is known as cardiomegaly. And a very easy way to detect cardiomegaly is through the chest X-ray. See, this is the midline of the chest. You take the maximum diameter on each side where the diameter seems to be maximum. They need not be on the same level. So if the two diameters are named as L and R just for left and right, then the cardiac diameter here is C equal to L plus R. Now you also take the maximum internal diameter of the chest. That again can be at any level, not necessarily at any of these levels. I think this is the maximum internal diameter of the chest. Let me call this internal diameter T for thorax. So when you divide C by T, this is called cardiothoracic ratio. And its normal value should be less than 0.5 or half. Whenever the value is more than 0.5, we say cardiomegaly is present. Let's see here. I think this is the maximum internal diameter of the chest. Now, if I draw a midline, then the right-sided diameter I think is largest here. The left-sided diameter I think is largest here. So if you add up these lines, I'm just showing you as a comparison. This is the left component. This is the right component. Obviously, this is more than half of the thoracic diameter. So here the cardiothoracic ratio is definitely more than half. And so we say cardiomegaly is present. Okay. So the chest X-ray can also help you to find out cardiomegaly. You can also get prominent hilar markings, which indicate that there is congestion of the pulmonary veins. You see, there is so little venous marking here, and comparably, there is so prominent venous marking here, almost like a bat wing appearance. So this is the importance of chest X-ray in evaluating cardiac diseases. Another important investigation you can do is echocardiography. That literally is the ultrasonography of the heart. So this is an echocardiogram. It shows the left atrium and the left ventricle on this side and right atrium, right ventricle on this side. Can someone tell me what is the diagnosis shown here? You can see a blobby mass going up and down. So what is the probable diagnosis? Wonderful. A false tumor myxoma, if atrium is obstructed, especially site myxoma. This was only example, but use different kinds of investigations. Also, do not underestimate baseline diagnosis like ECG, blood sugar and lipid profile for atherosclerotic risk assessment, thyroid function test to test for any tachycardia, and creatinine, sodium, potassium to look for the renal function. So if you follow these basic steps, I'm sure it is very easy to investigate a cardiac disorder. Today, I wanted to give you an overview of how the heart is examined. And tomorrow, in 2 stages, we'll try to discuss specific cardiac valvular diseases and how they look clinically and how we can investigate and treat them. So, Pranava and Vishnu, this was today's presentation.
Thank you so much, sir. It was really a wonderful session. Does anyone have